Welcome back, everyone. I'm Harshal, and you are tuning into a high-stakes masterclass on what is literally one of the most scrutinized, highly audited areas in all of medical coding. Today, we're tackling Part 31 of our series, Consultation Services. Specifically, we're looking at CPT codes 99242 through 99255. Now, if you've been working in the medical billing and coding space for any amount of time, you already know that these codes are absolute magnets for auditors. It's like a giant target on your claim. Get them right, and you're golden. Get them wrong, and you're looking at denied claims and a whole lot of lost revenue. Okay, let's dive into this. Here's our syllabus for today's explainer. We're covering 1. Defining a medical consultation, 2. The 3 R's rule, 3. Consult versus transfer of care, 4. Outpatient consultation codes, 5. Inpatient consultation codes, and finally, 6. Documentation and compliance. Mastering these 6 steps is the absolute key to bulletproof coding, so let's get right to it.
Starting off with Section 1, defining a medical consultation. So, what exactly makes a visit a consultation in the eyes of the CPT guidelines?
Well, let's start right at the foundation. Before we can even think about picking a code, we have to establish the base rules. Now, what's really interesting about this slide is the exact phrasing directly from the CPT rulebook. It specifically states that a consultation is a type of evaluation and management service provided at the request of another physician or appropriate source to recommend care for a specific condition or problem. That request part, totally non-negotiable. If a patient just wakes up and decides on their own to go see a cardiologist because they feel palpitations, that's not a consultation code. No way. That's just a standard new patient visit. A true consultation relies entirely on one provider actively asking another provider for their expert opinion or advice.
Which brings us to Section 2, the 3 R's rule. This is the golden mnemonic every single medical coder was memorized to survive a consultation audit. Because the definition of a consult is so incredibly strict, the coding community came up with these 3 R's. Step 1 is the request. There must be a documented request from another provider in the medical record. It can't be implied, it has to be explicit. Step 2 is render. The consultant actually sees the patient, evaluates them, and forms an expert opinion or treatment plan. That's the cognitive work, the heavy lifting of the visit. And step 3 is the report. Now, listen up because this is where so many claims fail. The consultant absolutely must prepare a formal written report and send it back to the requesting provider. If you have the request and you render the service, but you just kind of keep the notes in your own system and never actually communicate that formal report back to the primary doctor, you simply cannot bill a consultation code. All 3 R's must be clearly visible in the patient's chart. Moving right along to Section 3, consult versus transfer of care. Crossing this line is honestly the fastest way to a denied claim. So, the crucial point is understanding the difference here. Assuming you have the 3 R's down, you have to avoid this massive pitfall. On the left side, a true consultation means the specialist simply recommends care or gives advice, all while the primary provider continues to manage the patient. But on the right side, a transfer of care means the specialist takes over the management of that condition entirely. And if that happens, you have to use standard new or established patient codes, not consult codes. And I need to give a massive warning here. Medicare, or CMS, eliminated payment for consultation codes entirely. Yep, they're gone for CMS. For Medicare patients, you do not use consultation codes at all, even if the visit perfectly meets the definition. Instead, you're going to use standard initial hospital or office codes, and if the provider is the admitting physician of record, you append modifier AI. Always, always know your payer policies. All right, Section 4, outpatient consultation codes. Let's shift our focus to the practical application for the payers that actually do accept these codes, starting with the office and outpatient settings. With that massive Medicare caveat out of the way, let's break down the codes for outpatient consults, which range from 99242 to 99245. This is a perfect slide to screenshot for your notes, by the way. Notice that you can select your level based on either medical decision-making, your MDM, or time. For 99242, you're looking at straightforward MDM or meeting a 20-minute time threshold. 99243 requires low MDM or 30 minutes. 99244 steps up to moderate MDM or 40 minutes. And finally, 99245 is for high-complexity MDM or hitting that 55-minute threshold. And remember, this encompasses both face-to-face and non-face-to-face time spent by the provider on the actual date of the encounter. Section 5, inpatient consultation codes. Let's move to and see how this builds as we transition from the outpatient clinic over to the hospital inpatient settings.
So the rules shift just a bit here. For inpatient or observation consultations, we use codes 99252 through 99255. The MDM levels remain exactly the same, straightforward, low, moderate, and high, but look at the time thresholds. They are significantly heavier for facility settings. 99252 requires 35 minutes. 99253 needs 45 minutes. 99254 demands 60 minutes. And 99255 tops out at a massive 80 minutes. Now, here is a remarkably strict CPT rule you absolutely cannot forget. Only one consultation may be reported by a consultant per admission. That's it. You get one shot at the consult code. Any subsequent visits by that same consultant during the exact same hospital stay, well, they must be reported using subsequent hospital care codes, not consultation codes.
And that leads us to our final section, Section 6, Documentation and Compliance. Because knowing the codes is only half the battle. Proving them on paper is the other half. We really have to remember the core reasons why accurate documentation matters so much. First and foremost, it's about clinical continuity. Your notes inform the requesting provider and ensure the patient gets safe, cohesive care. Second is legal protection. A well-documented chart is a defensible record of care. Third is financial compliance. The chart literally has to justify the E&M level you're billing for. If your documentation is vague, if it lacks a clearly stated request, if the MDM isn't obvious, or if there's no solid proof that a report was sent back to the requesting provider, you are going to fail an audit, for sure. Downcoding, denials, and recruitments are the direct result of poor documentation, not necessarily poor clinical care. The phrase, if it wasn't documented, it wasn't done, is the absolute law of the land here. So I want to leave you focused learners with a provocative thought about your own coding habits and the providers you work with. Take a look at your last 5 consultation claims. Is your documentation truly robust enough to survive a consultation audit? Can you point directly to the request, the render, and the report? If not, it's probably time to refine those templates and educate your providers. Thank you so much for joining me for this explainer on consultation services. Keep learning, keep verifying those payer policies, and keep coding with confidence. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.